fantastic. Really appreciate your organization, orchestration of this trial. Congratulations, Dr. Farron, Dr. Leon. I think this is what we've been looking for, and I think this is a call, no pun intended, but that we should all rise in the cath lab and use physiology more. I was also happy to see that roughly half of the patients had intravascular imaging, so I think this is a really good cutting-edge study. And this is what we've been looking for, is a clinical impact of what it is to use FFR angio or other angio-based FFR modalities. If I take the contrarian view for just a moment though, we know that Soroy's and others from Galway looked in a core lab and didn't quite find the area under the curve that we had hoped for, right? Many of the angio FFR programs had an AOC of about 0.75 versus the 0.92 that we saw in smaller studies. And the other thing that they showed was quite interesting is there was a bit of a discordance between LAD and circumflex right coronary artery. And so I'd like to hear if you have any comments about that before we maybe turn to other panelists. And in particular, what they showed was false positives were a bit higher in the right and the circumflex. And I notice here you've got about a fourth more procedures in the CathWorks utilization. And so it makes me wonder, while we do save time on individual cases, if we're doing more cases, then the total amount of time may be longer. So see if you have any comments to respond to those.
No, thanks so much, David. And I think all those points are things that people would be thinking in this space. So a few things. The first is that Soroy's analysis did not actually include the CathWorks algorithm in the analysis. And I would caution folks from attributing a class effect to all of these devices. The actual algorithms differ, and actually the requirement for a number of angiograms substantially differs. This one, despite my chagrin, because I'm an interventionalist and I just want to use 2 views or 1 view to calculate the values, insists on using 3 views. But anybody who does angiography knows that when you do an angiogram, you can hide a lesion, you can show a lesion if you just look at a single view. And so if it's garbage in, it's going to be garbage out. And I think one of the things that I most admire about this technology is they've stuck to their guns and said you need to have 3 views to be able to analyze the data. As far as the LAD issue, that's one of the reasons why we pre-specified as a subgroup. And notably, the rates of events were actually lower despite the overall higher rate of revascularization with this technology compared with FFR in the LAD subgroup. And then I guess the final question was with regards to procedural time. We actually accounted for procedural time in that analysis, and despite more PCIs, the overall procedural time was less. I'm certainly not advocating for doing more PCIs though. I think that one of the benefits and beauties of using physiology is that you actually don't do unnecessary PCIs. But most of the PCIs that likely fall into that group are around the cut point where outcomes are largely similar. So we still have to be good clinicians. We have to treat the patient for the right reason. But the question is can we use tools that help us do that better, especially when we know that the tools we already have, we just don't use as much. So for me, that was what was encouraging about these results.
I'll open it up to other panelists if you have additional questions.
I can ask a question. Do you actually think that we will increase physiology with having a tool like this? Or do you think that people will be lazy with 3 views, maybe more contrast? What's the cost of this? You want to tell us what you think is going to happen? What you think future?
Yeah, certainly we have to continue to educate. I think this does make it easier because we know that physiology makes sense, and I definitely think for some interventionalists they don't want to do physiology because they want to put in more stents. But I think we've gotten past that point now, and a lot of us do want to do it, but the steps it takes to go through, I did that deliberately. I didn't present it very well in the beginning, but I did it deliberately to show what we go through to do physiology. So anything we can do to get that information in an easier way, I think will certainly change adoption. There's a reason why we all went from the cameras that we used to have to cameras on our phones, because it just worked easier. And I'm not saying this iteration of this technology is the answer to that. Everything needs to be iterated. But with software, things can be iterated much faster, and hopefully by making it more accessible, it'll be used more often.
One last question. Where do you see this fitting in with CT FFR, patients who come to the lab already with a CT?
So super complementary. There are many cases that I use both in practice where the CT may be equivocal, and so then I'll run this analysis. CT-FFR has dramatically changed how we can talk to patients up front. Instead of in the New York area where somebody sees a 70% lesion and actually the radiologist sends the patient to the ER asymptomatic because they're worried if the lesion is going to cause an MI, with CT-FFR you can kind of resist that urge. That is very complementary to this. If you have to go to the cath lab and do physiology, don't put a wire down, just analyze it this way, use the two together to make your decision.
I'm gonna ask one very brief practical question for you. As you've incorporated this into your workflow at Columbia, we've just started at Mass General as well using angio-FFR. You have to use a higher frame rate to capture the angiograms. Are you starting off every patient at a higher frame rate just in case? Or do you go back and take the pictures with dedicated views after you have enough suspicion that you know you want to conduct an angio-FFR? We're all trying to reduce radiation exposure to patients, to operators. This is a huge commitment to wellness in general. And I know these are negligible amounts, but I'm just curious about your workflow.
No, so actually, that we'll probably have to talk afterwards about the cath lab setup, but we did not change our frame rate at all. We don't use excessive frame rates. We actually published our data, and we're able to do it with the current frame rates that we have.
Thank you.